joint. But interestingly, if our hypothesis is correct, remember we had high elevated levels of TNF-alpha as one of the pro-inflammatory cytokines. So it makes sense that it would be reasonable to test if topical TNF-alpha applied, neutralizing antibodies to TNF-alpha applied to the surface of the wound would enhance healing. And in this recent paper, they published that of these wounds after 4 weeks with one therapy at 4 weeks and then a second repeat therapy at 3 weeks, that they were able to reduce the initial wound area by 56 in 6 of these 14 ulcers. And within 8 weeks, 5 ulcers healed and 4 others were reduced by greater than 75 cents. So for a total of 12 or 14 of these very chronic, difficult to heal ulcers actually responded to this topical anti-TNF-alpha therapy. So this, again, I think provides good quantitative data that says that this general hypothesis of molecular pathophysiology of chronic wounds is correct in that chronic elevation of inflammatory cytokines is part of the problem in preventing the wounds from healing. Another adjuvant dressing that is based upon this concept of the molecular pathophysiology of chronic wounds comes from the idea of trying to reduce the levels of proteases in chronic wound fluids. A product consisting of oxidized regenerated cellulose and collagen has been evaluated in at least 2 clinical studies of chronic venous ulcers or chronic diabetic foot ulcers. The idea here is that this collagen-containing dressing actually is a substrate sink that pulls the proteases from the chronic wound fluid and holds them in the dressing because it floods those proteases with much higher concentration of substrate in the dressing than in the wound. So what this really does is, as a biochemist, it sucks the proteases into the dressing, lets them chew up the dressing, rather than chewing up the good matrix proteins that are in the wound bed. And it also has the principle and the properties then of preserving the endogenous amount of growth factors that are in the wound. And again, just showing from data from Lisa Ovington that platelet-derived growth factor applied to chronic wound fluid in a test tube is just totally degraded within a few hours. Whereas if the chronic wound fluid is applied along with the oxidized regenerated collagen, oxidized regenerated cellulose collagen dressing, the amount of PDGF that survives in that test tube reaction is about 80%. Gauze has no capacity really to do this. It doesn't have any ability to actively hold on to those proteases, and PDGF in a test tube in chronic wound fluid is not preserved in the presence of gauze. Another approach is to try to reduce the expression levels of the proteases in chronic wounds. Another dressing that is available in Europe and has recently been approved in the States consists of a mixture of cations that actually has the ability, because of the influence of cations on gene expression, to reduce the expression of these proteases and cytokines in cells of culture. So again, the idea being that by altering the pattern of gene expression within the chronic wound, here showing immunostaining for MMP2, another matrix metalloproteinase, at the start a very inflamed, very high MMP level after 6 weeks of treatment with this mixture of cations, changes the pattern of gene expression within those cells by suppressing MMP production, leading to reduced levels of MMPs in the wound and a progression on to healing. You don't always have to use the most expensive and exotic approach, whether it's a dressing or a neutralizing antibody or a mixture of cations. Turns out our old antibiotic friend doxycycline has the accidental effect of inhibiting metalloproteinases because of its structure. So looking at this left panel here, you can see that doxycycline has the accidental property of being a competitive inhibitor of matrix metalloproteinases. So if you take MMPs, put them in a test tube, add doxycycline, it inhibits those activities very dramatically in a test tube. It also has the unexpected effect of inhibiting the TNF-alpha converting enzyme, or TACE. TACE is a metalloprotease. It is not a matrix metalloprotease. It doesn't prefer collagen. It is very exclusively preferring the precursor, the inactive membrane precursor of tumor necrosis factor alpha, and it cuts that and releases the TNF-alpha from the membrane of the cell so that it is now active and able to diffuse through the matrix and recruit inflammatory cells. You can see here in this bottom panel, if we take macrophages in culture, add lipopolysaccharide to stimulate release of TNF-alpha compared to control, this is what normally happens in the wound. Massive amounts of TNF-alpha reduced. If we add increasing amounts of doxycycline, up to around 100 micrograms per mil, which is clearly achievable in a wound fluid, that you can essentially eliminate the release of soluble TNF-alpha from those cells because the doxycycline is inhibiting the TACE enzyme. Doxycycline also has the unexpected effect of reducing the synthesis of nitric oxide, and in some chronic wounds, they have very high levels of nitric oxide. And you remember nitric oxide can react with other molecules and produce damaging components, the peroxynitrite, for example. And that synthesis of that enzyme is actually reduced by the doxycycline acting at the gene level. And then finally, the fourth effect of doxycycline is indirect. It turns out that the major inhibitor of neutrophil elastase, the serine protease that's very damaging and high in many chronic wounds, is our old friend alpha-1 protease inhibitor, or alpha-1 antitrypsin. This is the natural inhibitor for neutrophil elastase that we have in our blood. In chronic wounds, the alpha-1 protease inhibitor levels are low because MMPs love to chew up alpha-1 antitrypsin, or alpha-1 protease inhibitor. This is the effect then of elevated MMPs in chronic wounds is to reduce or destroy the natural inhibitor of neutrophil elastase, allowing it then to have off-target effects and destroy growth factors and matrix. So by inhibiting the MMPs, what happens in a wound is the alpha-1 protease levels are not reduced. Indirectly, the doxycycline inhibits neutrophil elastase by preserving the levels of the natural inhibitor for alpha-1, elastase alpha-1 protease inhibitor. So does this actually translate into anything that has clinical relevance? Well, there are two ways you could consider delivering doxycycline. You could give it orally, or you could give it topically. In these upper two panels, oral doxycycline from studies done with Bob Diegelman dramatically reduced the amount of inflammatory cells in punch biopsies taken from this pressure ulcer 2 weeks after initiation of oral doxycycline at typical antibiotic levels. However, my bias is that topical doxycycline is the preferred way to try to deliver doxycycline because we can get much higher levels and we don't have the adverse systemic effects of giving a systemic antibiotic. And so in a very pilot study done with Gloria Chen, we looked at the ability of topical doxycycline to heal chronic diabetic foot ulcers. And after 21 weeks of treatment, all 4 of the doxycycline patients, when the code was broken, had healed. One broke open a little bit, but then went on to heal a little bit later. Compared to the 3 vehicle-treated patients, 1 of those healed, 2 of them did not. After the 20-week structure of the closed-label randomized study, 1 patient was allowed to cross over onto topical doxycycline treatment and begin to heal. So what does this mean? It means that at least we're not doing anything bad with doxycycline. And we hope that these types of very pilot safety data in a phase 1 study will actually translate into a benefit that we'll see in a current phase 3 study that we're doing at the University of Florida and at several other affiliated universities. Growth factors are the keys to making wounds heal. And there are multiple studies in the literature. These are just examples of 5 randomized control studies showing that topical application of various growth factors, platelet-derived growth factors, fibroblast growth factor, granulocyte macrophage colony-stimulating factor, keratinocyte growth factor, epidermal growth factor, all of these have been reported in chronic wound studies to promote healing when the wound bed is properly prepared. The problems that have been encountered with the Regranex product when it